Josh, I'm going to ask us to hold a little bit. I'm going to pass a slide deck that I've assembled very quickly over to Dr. Rab. Dr. Rab, do you want to present it?
Yeah.
Or would you rather that Josh present it?
And we need to get started right away, okay?
Okay.
So Josh, are you ready to go?
Yes, please proceed.
Hello, everyone, and welcome to the monthly SCAI Bifurcation Club webinar. This is a webinar that has brought a lot of interest internationally. And today we have an excellent group of speakers with a very full schedule. Special thanks to Medtronic for supporting this program. And you can all get credit from the SCAI website for CMEs and MOCs. Now, without much ado, I'm going to hand this over to Xiaoliang Chen, my friend from Nanjing, a real true leader in the bifurcation world, who will moderate this session. We have excellent speakers with Dr. Nam from Korea, Dr. Mamas from the UK, Dr. Zavik from Canada, and we have Dr. Koo, a national expert in coronary physiology, pretty for side branch stenosis and real world leader in that area. We also have our panelist, Dr. Puno Velagapudi, who is going to join us or has joined us. And our chat moderator is our senior Emory fellow, John Visco, who will take your questions. So without much ado, I'll go to hand over to Xiaoliang to start the proceedings. Xiaoliang.
Well, thank you, Dr. Rob. I think there will be a very attractive session to tell our audience how to treat osteal lesion. So I think it's my great honor to introduce the first speaker, Dr. Chang-Woo Nam from South Korea, to present an update on osteal side branch stenosis. Please, Dr. Nam.
Thank you. Okay, I will prepare my slide. So thank you very much for kind invitation for this wonderful SCAI Bifurcation Club webinar. So I will talk about the update on the osteal side branch stenosis. So I will deal about these 5 questions about the 001 bifurcation reason. First, how many bifurcation reasons are here in our daily practice? So to solve this problem, I made the extended bifurcation registry, which include COVID 2 and 3, more than 5,000 patients. And from the Italian group, we can merge the RAIN registry around 3,000 patients. So totally 8,434 patients was included for this registry. And we found that the Medina 001 reason 345 patients. So as a percentage, 001 is 4.1%. So it's relatively rare situation in daily bifurcation PCI. And second question is behavior of 001 bifurcation lesion. Is it malignant or benign? So previously, we published the COVID-2 from the COVID-2 registry data. So we compare true bifurcation lesion versus non-true bifurcation lesion. Not only MACE, but also cardiac death MI was higher in true bifurcation lesion after PCI. So we may say true bifurcation lesion has a malignant behavior compared to non-true bifurcation lesion. How about this extended bifurcation registry? So when you compare the true and non-true bifurcation lesion, true bifurcation lesion 3-year MACE rate around 13%, and then non-true bifurcation around 10%. How about the 001 lesion? Even though 001 lesion is a non-true bifurcation lesion, but behavior is nearly, MACE rate is 14%, as a behavior like a true bifurcation lesion. And third question is, what are unique features of a 001 bifurcation lesion? As we know, the osteal side branch lesion has a negative remodeling, so it can easily overestimated by angiogram. So it includes negative remodeling. So if we treat with the PCI, that region has a higher recoil and lesser acute gain. And also, there is a risk of injury to main vessel when treating side branch. Another issue is when you treat the side branch, because it's a side branch, it's smaller vessel diameter, and we can use a smaller stent size, and then there is a higher risk of stent failure. And most important thing is angiographic 001 bifurcation lesion is not always true bifurcation 001 bifurcation lesion. I will show you the case. This case. This is osteal circumflex region. So angiographically, we can say easily it's a 001. coronary region. However, if you see the IVUS, definitely OCR circumflex has a significant disease, but angiography looks normal. But this left main has a severe calcification with a more than moderate plaque, and it was extended to OCR of RAD. So if you again evaluate by IVUS, it is at least 101 lesion or 111 lesion. And fourth question is, what are the treatment option for 001 bifurcation lesion? So we can say that it's a three option. First is medical therapy. Second is the balloon angioplasty with the low-coated balloon. And third is a stent strategy. But even though it's 001 lesion, I would like to emphasize medical therapy alone, because we already know the side branch has a lesser myocardial burden. So most of 001 bifurcation lesion can be treated, if patient is stable, treated with medical therapy. And second is balloon angioplasty. Even though the balloon angioplasty is not quite acceptable, but nowadays we have drug-coated balloon. It has a very strong effect, because we can reduce the metal burden and we can preserve the native coronary bifurcation anatomy without stenting. And also we can reduce the risk of thrombosis and the duration of death. However, still there is some issue about the DCB treatment of side branch. There is a high risk of elastic recovery of a side branch. Also, we already mentioned about that because of negative remodeling. And second thing is a risk of coronary dissection to a main vessel during the side branch treatment. And third issue is still there is a large clinical data of a DCB in side branch treatment. And finally, the question is a stent strategy for 001 bifurcation lesion. We can treat it with provisionally one stent, and we can treat also two stent strategy. If you see the last 15 years trend, initially we treated with the two stent strategy for the 001 bifurcation lesion frequently, but recently we have a more approach with provisionally. Nearly 90% was a provisional approach, and one stent strategy was applied. And when you compare the clinical and procedural data about when you treat 345 patients with a stent strategy, we separate as a one stent strategy and two stent strategy, and see the region characteristics. And the two stent strategy, nearly 90%, more than 90% was left main bifurcation or RAD diagonal branch. But one stent strategy, 60% was that reason. And see the procedural technique, because the two stent strategy mostly the performance of kissing balloon technique, but one stent strategy, nearly 2/3 of patients kissing balloon technique, and then pod was applied, nearly 37%. And we compared the QCA analysis, nearly 2/3 of patients only available QCA analysis, because we cannot get the QCA data from Bayesian registry. However, we can see the trend. The two stents was a user situation is a side branch reference special diameter 2.1, but one stent strategy relatively side branch reference special diameter was larger than two stent strategy. That's why we can simply cross over from the main vessel to side branch. And the percent diameter stenosis, even though it's a 001 lesion, two stent strategy has a relatively some disease in the main vessel distal part. When you compare the primary endpoint, that's MI, TVR, and stent thrombosis, one stent strategy and two stent strategy was not different until 3 years. Even though we separate the one stent strategy just crossover without main vessel throat opening, but the outcome was not different. So simple approach was quite acceptable in this region, and we analyzed a subgroup as a age, gender, and diabetes, and ACS clinical presentation, left main, non-left main. All the subgroup analysis did not differ to one stent strategy and two stent strategy. So this is my last slide, summary slide. So the incidence of angiographic 001 looks rare, 4.1%. And the recent year, there has been a trend to prefer one stent strategy. Although there was no imaging data in our analysis, but the angiographic 001 lesion looks, it is not always real 001 lesion. And then additional evaluation of intracoronary imaging or physiology would be helpful to assess the reason. And the clinical outcome after PCI appears very unfavorable. Therefore, we have to take a higher risk than our thought. So it is imperative to consider various treatment modality when we decide on the most appropriate approach for each 001 bifurcation region. Thank you very much for kind attention.
Well, thank you, John, for your wonderful presentation. I'd like our panelists, Dr. Koo and Vladimir, do you have any comments?
I think that's a great talk. I just also think that we really don't have randomized data at this point. There is the small study that actually looked at single institutional experience of about 70 patients, comparing the crossover versus osteal stenting technique in the single stent strategy. And I think they noticed that the crossover technique was better in terms of TVR and restenosis. So I just wanted to add that comment. When we use the single stent approach, probably a crossover stenting would be a better option than nailing the ostium.
Thank you, Pamela. Dr. Koo.
Yeah, I also think it's a great presentation. More and more data, recently MAMAS data also added some additional evidence on this very complicated issue. But we have to understand that how difficult it is to collect these several hundred cases from this big, large registry data, so that it may be very difficult to make a randomized trial. But we have to extract as much information as possible. But the one thing I'd like to stress is that as Dr. Nam mentioned, that the 001 is very difficult to define by angiography, so that we need a physiology and imaging to define or to select the proper treatment strategy. But it's good that we have a very nice data from the Dr. Nam's paper.
All right, so in the interest of time, we'll go ahead, okay? So I'm going to introduce Xiaoliang Chen, who's well known to all of us. He's going to talk about osteal left circumflex case and update on the large China osteal side branch DCB registry. Xiaoliang.
Okay, thank you. I think now you can see my slides. So the topic is, how should I treat isolated radial circumflex osteal stenosis? Actually, according to the Medina classification, so isolated distal left main lesion is very rare. So according to the definition of bifurcation lesion, so diameter stenosis minimum 50% within 5 mm of two daughter vessels, for example, osteoid and circumflex. And also, the presence of POC lesion does not increase the complexity. It means very, very rare rate of the lesion localized as a POC area. So nextly, also we have 4 more different classification for distal left main bifurcation lesion according to the Medina classification. So in general, even for isolated distal left main lesion localized as a distal left main, so almost greater than 80% of lesion extend into the RAD or circumflex, so which will increase the complexity of stenting technique. But for Medina 111 and 011, true coronary bifurcation lesion, usually for distal left main, this true coronary bifurcation lesion, two-stent approach, but which are dependent on the side branch disease severity. So let's back to the topic today for isolated circumflex, osteal circumflex, or osteal RAD lesion. So both are classified by Medina 001 or Medina 010. So as John has presented, there are multiple choice of stenting technique. For example, for precise position of short stent to cover the osteal lesion. So the drawback of this technique is a high rate of geographic miss. Secondly, if even the protrusion of the stent into the main vessel very shortly, but still there will be a lot of stent floating in the main vessel. That will be very dangerous to get stent thrombosis as well as restenosis. Secondly, if we put much more stent into the main vessel because of the wide discrepancy in vessel diameter, so we need to use more large NC balloon to post-dilate to make a valve position of the main vessel stent. And also, if we post-dilate too much, so the severe shifting of carina or even plaque into the side branch, into the surface or either RID will cause the complexity of stenting technique. It means probably we need to cross over from provisional to two-stent technique. So let me focusing on the introduction of one isolated osseous surface disease I just did a few weeks ago. So patient is 72 years gentleman. He presented unstable angina for almost 2 months. So this is the AP caudal angiography. We use the same French guiding from a transfemoral approach. So you can say osseous surface looks like a very severe disease. Even this is a still imaging, but we also can see there are some haziness as a osseous surface. Angiographically, there is no more severe plaque burden as a proximal RID, but it's still there is some plaque as a distal left main. So it could be classified by Medina 001. But actually, if we use intravascular imaging, I think it could not be classified by Medina 001. So for this case, we check the IVOS pre-procedure. I tried to find out if there is any severe disease. Luckily, from IVOS, so the distal left main has only a very, very mild plaque. So for this case, I think we can have different choice of stenting technique from T-stenting technique, provisional T-stenting technique, or TIP technique, or even Coulomb stenting technique. But I think stenting technique selection is dependent on the patient specificity, depends on the lesion specificity. But for this case, I used the stop and the pullback stenting. So for this case, you can see I use a 3.5 NC balloon, crossover from proximal RID to left main, and another 3.0 NC balloon in RID, another 3.0 SES stent, DES stent, very gently pull back from the proximal surface to very, very osseous surface. During the inflation of the balloon in the left main, once we feel very strong resistance from the surface stent, so we can stop pull back and just inflate the surface stent at its position. This is the inflation of surface stent. It's a 3.0 stent. So after stenting technique, we recheck the IVOS again. From the image, you can see the surface stent is fully expanded. Also, a very, very mild protrusion, almost just one straw into the POC area. I think this is a very good point. So next part, according to suggestion by Dr. Rob, I'd like to use 2 slides to briefly introduce our DCB bifurcation trial. It's a multi-center randomized clinical trial. So basically for 2 coronary bifurcation lesion, Medina 111, 011, or 101, with side branch diameter minimal 2.5 millimeter, but the side branch lesion length should shorter than 10 millimeter. So I think this is a typical definition of simple bifurcation lesion by definition criteria. So 2 wires in main vessel side branch go through stenting main vessel and the port technique. After port, if the side branch, the osseous side branch lesion diameter stenosis minimal 70%, team flow less than 3 or greater than type B dissection. So the patient will be randomized into provisional stenting with NC balloon, convention NC balloon. And another group is a provisional with the DCB group. For both groups, after port technique, we need to use another NC balloon to dilate osseous side branch But in the DCB group, after dilation using NC balloon, we need to use a additional drug coating balloon to dilate. A drug coating balloon is a paclitaxel coating balloon provided by Bifurcation. After dilating side branch, we need to do kissing inflation using NC balloon and another NC balloon in the main vessel, followed by final port technique. After final port, if the thin flow in side branch less than 3, or if there is a presence of type C dissection inside branch, we need to use a second stent inside branch, followed by final kissing and one more port technique. The primary endpoint was a 1-year MACE for this study. So in general, for this trial, I think 3 key points are simple bifurcation lesion included. After stenting main vessel, then NC balloon or DCB to treat side branch. This is a multi-center trial conducted in 16 Chinese centers, 27 centers from 6 countries. So we finished last enrollment in June last year. In June this year. So hopefully next 2024 June, we can report the 1-year clinical follow-up. So far, we are waiting for the completion of 1-year follow-up. Also for this trial, we have 2 core level. One is for angio, another one for IOS. But for this trial, intravascular imaging, for example, IOS is not mandatory. It's left as a physician discretion. But finally, we need to find out if there is any difference amongst different subgroups. So thank you very much. These are my presentation. Thank you.
So any questions for the other speakers and panelists?
So congratulations. I mean, yet another fantastic trial from your academic center. I guess one of the questions that perhaps many would consider is that we've got randomized controlled trial data from the French group, the KISS trial, that shows no benefit of doing KISS in these provisional cases. So in retrospect, do you think that perhaps you should have had 3 arms, 1 no KISS, 1 KISS with normal balloon, 1 KISS with drug-coated balloon?
Yeah, well, thank you very much for your excellent question. Actually, since the launch of DCB in China, not only in China, I think also in Asia countries, so DCB is off-label used too much, particularly for bifurcation lesion. So I think we need to provide a very strong RCT to show the evidence to confirm if DCB is benefit, is priority to the convention NC balloon. Secondly, about this study, basically we tried to design 3 groups, but finally we changed our idea because of the large number, sample size too big, cost a lot, and take a long time. So finally, you say for these 2 groups design, so the total number of patients is greater than 700. And unluckily, since the initialization of this trial, COVID-19 came up. So it took so long time. Thank you.
Mamas, remind me, was the French trial all true bifurcations? Because that might be the difference here, right? It's I don't know if too many of us would not recross and do a KISS in a true bifurcation, especially left main, for example.
I think it was non-left mains.
Yeah, but was it all true bifurcations?
I can't remember.
Okay. Yeah.
So one thing that always comes up, Dr. Koo, the physiology question, okay? We need to answer a physiology question of the side branch. Can you address that?
Yeah, so I think this is a kind of a difficult question to answer, so that generally, even physiology anatomically, the lesion as shown by this, Dr. Chen's presentation slide, that it is connected So practically, when it is truly connected, it is very difficult to differentiate even by either imaging and physiology. But when you do a very careful pullback, and sometimes it's helpful to use the non-high pressure pullback with the imaging co-registration, you can at least define where is the more significant physiologic lesion in comparison with the other elements. But physiology, I can say that physiology cannot perfectly discriminate the true lesion location.
Off of that, we saw a few examples today where angiographically it didn't seem like there was any disease, but then on IVUS there obviously was. From the chat, there's a question: do you feel as a panel that imaging is mandatory in every bifurcation?
So for complex lesion, there has been lots of data. We are collecting more and more data that imaging is necessary, but I'm not sure that for the general bifurcation, we still don't have an evidence for supporting the use of the bifurcation. But we have, October data and Renovate data and very large registry data supporting the use of imaging, intravascular imaging in left main and complex two stenting cases.
All right.
think
Are there
the
one comment
October-
about the?
Go ahead.
Okay.
Go ahead, please.
Okay, so I'd like one comment about the imaging guidance. So if we apply the simple approach, sometimes we don't need to confirm the imaging, but if you do the complex procedure, especially two-stent strategy, two-stent strategy needs rewiring again and balloon again, and then we have some abnormal procedure risk. So definitely imaging guidance would be benefit with a complex procedure. A simple comment.
Yeah, I think
Yeah,
the
just-
October data had almost 20% bifurcation lesions, right? I can't remember, it was left main bifurcations were about 20%, and they did better with imaging.
Well, and I think October had 100% bifurcations, right?
I mean, left main bifurcations were about
Yeah,
20.
no, I appreciate that. Yes, yeah, no, fair enough. Yeah.
Yeah, thank you. So I think now is the time to move to next speak. Please, Dr. Mamas to present bifurcation diagnosis. Dr. Mamas is a worldwide well-known intervention cardiologist. Go ahead, please. Thank you.
So thank you for your very generous introduction. Real pleasure to present this bifurcation case, which was started off by one of my colleagues. It was a 49-year-old gentleman presenting with an ACS, high sensitivity troponin elevated, risk factors esque smoker. You can see from the ECG anterior T-wave inversion. By the time he came to the cath lab, he was relatively pain-free. Now, this is the angio, and you can see some disease in the LAD, but what is obviously a 001 tight lesion in the diagonal. You can see that there. And let me show another view. This is the PA cranial view. And again, you can see some disease in the LAD, but effectively a 001 diagonal. Oops. And the rest of the coronary vasculature was relatively benign. So you can see some minor plaque disease in the circumflex, and the right was relatively normal with some minor plaque disease. So my colleague pressure wired the LAD and initially tried to manage this medically. And did a treadmill test on the patient, which was very strongly positive, at very low workload. So he appeared on my list the following week to treat. So perhaps I'll stop there and ask the panel, what would they do?
Can you go back to the angiogram, please? And then we can discuss.
So it's a very interesting case, and we see this all the time. I think there was a very important point that was presented in the first few slides about, 1 in 5 of these branches usually supply more than 10% territory, right? It's known from that CT study. And then the other point that also we note from that study is the length of the vessel of about 72 was also
Yeah.
associated with that. So this looks like a long and pretty
This looks like one
decent
of those.
Yeah, and I think I would definitely treat this, particularly if the patient is having symptoms despite anti-anginal therapy and with a positive stress test. And then as far as the technique goes, obviously, you know, I would probably do a provisional from the left main into the diag.
So mamas, I think your case is a typical representative of the Medina 001 case involving LAD diagnose. So from our database, also from our previous clinical trial, most of bifurcation lesion involving LAD diagnose after provisional stent intended with one stent. So probably after 1 year or even 2 year, patient came to hospital again and presented very severe chest pain. So angiography confirmed very critical disease as they also diagnosed. For your case, I think there is only one big diagnose taken from LAD. Also, very critical lesion as they also diagnose. Definitely, I will treat diagnose. But before that, I will check IVUS or OCT for LAD to see if there is any space left for provisional. Thank you.
Okay.
So I also think it's an interesting case, so that it's great to hear that the most panels are starting with the clinical relevance and agree that this branch is really a clinically very relevant branch, which may cause symptoms. And I agree that this is a 001 lesion, and it's also nice to hear that the LAD FFR was negative, which means that this is a true physiologically and functionally anatomically and functionally 001 lesion. And for the treatment for that lesion, generally that kind of lesion is associated with the negative remodeling with some plaque, and FFR in LAD was negative. I will consider that my primary option with the try to fix this lesion with the DCB.
Okay, that's some great suggestions there. Interesting thoughts. I'll show you what I did. So, of course, radial first approach. I tried to deliver an OCT catheter, but it failed. It just was too tight. So I pre-dilated with a 2.5 by 12 millimeter balloon that you can see here, just to make some space. And you can see a huge amount of recoil with a conventional balloon. And I generally inflate my balloons to really quite high pressures. So with my standard balloons, I usually go to 18, 20 atmospheres. And you can see that it's really not done much. So I then, oops, where is that? Just, sorry, used why is this not progressing? A cutting balloon, a 3 by 10 millimeter Wolverine, just to cut it. And you can see that we're starting to get a much better expansion. As per my standard practice, I always OCT. I do 100% intravascular imaging in all of my PCI. This is the OCT run. You can see that there's quite significant fibrocalcific plaque in the LAD, in the diagonal. You can see that there's a reduction in the MLA. This is where I've cut it with the cutting balloon. You can see a big dissection there. And this is going back into the LAD. And you can see that whilst the LAD proximally looked relatively normal, there's quite significant plaque disease, which goes to the previous point of Dr. Nam, that suggests that, when we're assessing Medina class on angiographic assessments, perhaps we should be using intravascular imaging, because clearly normal vessels often have significant disease. So I then elected to use a drug-coated balloon. I used a 3 by, I did some more cutting balloon, and then used the 3 by 15 magic touch balloon. You can see that here. And this is the final result. So you can see quite a reasonable result with, very small or little residual stenosis, no obvious dissections angiographically seen, although clearly the OCT showed dissection. Patient remains well at 18 months follow-up. And this is just some data that my group has published from the e-Ultimaster registry. So this is a large global registry, 50 countries, 4 continents, 378 hospitals, 1 year follow-up, 35,000 patients. The primary endpoint of this registry was target lesion failure, defined as cardiac death, target vessel MI, and clinically driven target lesion revascularization. We've published this in JAHA, and you can see, consistent with the previous speaker's data, 3.5% of bifurcation lesions are 0, 0, 1. And similarly, these are unadjusted figures. You can see in black, the 001 has really quite high levels of target lesion failure, patient-orientated clinical events, cardiac death, clinically driven target lesion revascularization. Once you adjust for differences in baseline covariates, you can see actually the 001 lesions are the highest risk lesions. So you can see that compared to Medina 100, in terms of target lesion failure, once you've adjusted for age, sex, and other comorbidities, you have an independent 4-fold increase in risk. In terms of cardiac death, a 5-fold increase in risk. In terms of target lesion revascularization, again, you have a 5-fold increase in risk. So as per the other data that we've seen this evening, this is not a benign subgroup of patients. So in summary, in over 4,000 bifurcation PCI lesions, about 3% are 001s, and these patients have very high risks of target lesion failure, cardiac death, and clinically driven target lesion revascularization. So with that, I'd like to stop my presentation with 50 seconds to go.
Thank you. But in North America and the US, we don't have the drug-coated balloon. So positioning a stent perfectly is going to be difficult. I mean, so what did you suggest we do here? I mean, Vlad, do you have the drug-coated balloon in Canada?
Yes, we do actually. So I was going to say we have them in North America, just not in the US.
Okay. So, so I think, positioning it, Poonam, what did you do?
We have one, and that's the Pantera Lux. It's a very good balloon. I think we have another one coming soon. Sirolimus coated balloon, but the Pantera Lux has worked very well.
So Poonam, what do you do?
So I would do a single crossover stent. I don't think nailing the ostium would be really the best option here, just because of the angle, unless it's really a 90-degree angle and it's a large vessel. I never tried to nail the ostium, so we'll probably stent into the left main and then do a KBI and then part it.
The left main or the LAD?
Left main or the proximal?
Into the LAD.
Yeah.
Yeah,
I mean, I'm just uncomfortable, you're really staying the LAD if it's not needed. Putting the diagonal situation is different than ostial LAD that I'll present next. I have tried to use a cutting balloon. The result is acceptable. Leave it there. But there's a restenosis rate. If not enough, try to undersize a stent and try to position it as best as I can, taking multiple views into account, and go very gently, putting it after prep the lesion. So others, can you comment on it, or from different zones, Shaolin or Mamas? Or
thank you. Yeah, actually, I think if you don't have DCB available, so after cutting balloon, as Mamas showed, there is a type B dissection, as they also show diagonal. I think we can use one more non-compliant balloon to inflate at low pressure for a long time to seal the dissection. I think stenting will be very challenging because the diagonal looks like 30 millimeter in diameter, but the proximal ID looks like greater than 40. So I think it will be not easy to use a stent. That's my another strategy. Thank you.
I mean, I agree with that. I think trying to nail the ostium just leads to disasters. It never ends well. So I would personally just use a cutting balloon, a non-compliant, and I fully expect that the patient will probably come back down the line with restenosis. but I personally wouldn't stent it. If I was forced to, then I would do a crossover stent, like Dr. Velakapudi suggested, into the LAD and then pot.
Yeah, I think I would be careful about gentle inflation in the LAD. I would do the proper inflation and do the pot and make sure that we have good intravascular imaging showing no dissection. Important also, I think, and to do intravascular imaging of the distal main vessel, the LAD beyond, to make sure we have no significant dissection. Those are just my additional thoughts.
Thank you. So now I think it's time we have to move on. So the next speaker is Professor Tanvir Rab from Emory. To present up next, osteoarthritis case. Please, Dr. Rab.
Thank you very much. So I'm going to present this case, which I did recently, in a second, which is a 65-year-old female who presented with acute coronary syndrome. She has end-stage renal disease on hemodialysis, has diabetes type 2 with hypertension. Her past history is put in for left circumflex and mid-LAD stent placement in 2019. She has an active diagnosis of multiple myeloma and treatment, and has as a complication deep vein thrombosis, and is on warfarin therapy. So this is her angiogram. As you notice, the coronary vessels are calcified, consistent with end-stage renal disease, and she has this ostial LAD stenosis. You can see stents that are patent. I think there are 2 level stents in the circumflex, and there's a stent in the mid-LAD, proximal to which there's a eccentric 50% stenosis. I'll show you another view. So here we go. The different views are the same, and you can see that there is a chronic total occlusion of the right coronary artery that spills the collaterals from the LAD. The lesion in the mid-LAD does not appear to be critical at the edge of the prior stent, and the right coronary artery is totally occluded. It's got a stent jacket plus calcification. It's totally occluded in a stent segment beyond acute RV marginal branch. So we, let's see. So this is where we are. She has ongoing acute chest pain. That's why we brought her down. She would not be a good surgical candidate because of her end-stage renal disease and the fact that she has active multiple myeloma. Though in our center, she did have these comorbidities. We probably could offer her robotic Lima to LAD, which would be a great option for her. So I'll leave it up to the panel for discussion and take their opinions.
Yeah, if I could start, I'm not sure that I would call this a 0-1-0. There is significant tapering towards the distal left main towards the bifurcation, and not insignificant calcification. And I bet when you look at this with imaging, there's going to be significant lesion in that left main distally, as well as in the ostium of the circumflex. So this is not a straightforward lesion.
But for Medina classification, you have to have stenosis more than 50%, right? So I don't think the distal left main or the ostial circ really are more than 50% to qualify for the classification. Would I be incorrect in saying that, Vlad?
I don't think so, but you're absolutely right. I just think that the treatment is for sure going to involve the left main. That's my only point. It's not a straight. I guess the Medina doesn't really tell us so much about complexity, though it's a very useful and simple classification. The left main could be close to 50 distally.
Yeah, Tanvir, I think from geography, this is a spider view, right? Spider view.
Not true spider, but sort of a caudal view.
Yeah, very shallow. But I think by using multiple projection, probably the proximal circumflex looks like around 50% diameter stenosis.
Yeah.
So from my own point, I think it could be classified by Medina 1-1-1. True coronary bifurcation.
That's what a classified angiograph before even she would die. So the severe classification. So what I did was, go ahead.
I don't think there's any
Also, angiographically, so the osteo-LAD looks like very severe calcification. So for me, I will do IVL for AD, and also before the procedure, we need to check the IVUS or OCT.
So I did try to pass the Volcano Phillips IVUS and I could not pass it. Okay. So I dilated it 3.0 by 12 blind balloon. This is what the and so subsequent to that, I did an IVUS. Okay. So I'll play the IVUS.
Perfect.
So the IVUS moves around a bit, but the ostium, you can see 360 degrees of calcification, all around,
Very severe, very severely
and
calcified.
that is back to the left main, which also has calcium.
Wow.
I'm sorry, slipping in and out, but that's what the catheter did.
Also, this left main looks like 50% club.
Yeah.
So are we talking about a crossover stent here then?
Did you check IVUS for circumflex?
Yes.
No, I did not check the circumflex.
Okay.
Because that's the critical decision here. I mean, there's no doubt that you're going to have to stent into the left main. So I think the decision now is whether you go with one stent or two stent approaches. And really, for me, the IVUS would decide that. If there's significant plaque disease in the circumflex ostium, then I would go up front with a two-stent approach. If it wasn't so significant and there's a reasonable MLA, then I would probably just go provisional.
So one thing about the IVUS Volcano Phillips catheter, it's really rigid at the end, even the short-legged one. It was very difficult for me to negotiate into the circumflex. So that's why, and that's the only IVUS catheter I had. So we did. There was a significant recoil there. So I basically used a shock wave 3/0 by 12 there, and then after that, I followed by a basal measurement, a 3/0 by 26 drug-coated stent from the proximal leading into the left main.
So let's see what happened for circumflex.
Did you do any more non-compliant NC balloon dilations
It just
before
kept recoiling
stenting?
back blood. It just kept recoiling back the ostium.
No, I understand that, but after your IVL,
No, I did not do that.
You did not do that. Okay.
So then I went based on the left main measure of the 4/0 by 8 pot and did a wire recross into the circ to dilate the stretch with 3/0 by 12 balloon. Then came back and did a repot with the same 4/0 by 8 non-compliant balloon. And the pot balloon was measured to the left main. Okay. And this is the post stent results. Okay.
So pot balloon is amazing because it's very short, particularly very short shoulders.
I got a MSA of 7.7 for the ostium of the LED, and the distal left main was 13.6. There's still that D-shaped calcification left, but you can never perfect, okay, at the ostium of the LED. If you notice coming back, it's popping back and forth.
So I will generally still do high pressure NC balloon inflations after IVL before I try to deploy a stent.
Okay.
Yeah, I usually can also take up the IVL balloon after all the inflations to higher pressures, and that NC balloon as well. Yeah.
But I don't think you should go up more than 6 atmospheres in an IVL balloon. I mean, it does not give you any more gain.
No, for sure not.
Yeah.
The other question, I guess, was it a 3 millimeter LAD?
Yeah, it was my honest.
Yeah. Okay. Because I mean, with all the calcium, I'm not sure how we can be sure.
Good MSAs at the end, right? I mean, and this is the final angiogram here.
Yeah.
And one bit, another slide, I'll come back to this in just a minute. So this was the pre. Okay. And this is the post. And keep in mind, I did dilate the struts into the circ.
Yeah, my another comment is that because the patient presented a non-STEMI, right? So the ID should be a target vessel. So if we check our baseline, I was for some flags, probably I will use two-stent technique.
In this situation, you use two stents.
If we have IVUS image for some flags.
Yeah. I think even at the end of the procedure, I would have just imaged the circ as well as the LAD, made sure that the carina and everything looked okay on the circumflex side. I mean, usually it's never physiologically significant, but sometimes you may notice something that may need a stent.
Yeah.
But at least by angiogram, I do not think the osteocirc is involved and needed anything has been done. I just wanted to keep in a renal failure patient procedure simple, okay, with a one stent strategy and not put two stents in, because in renal failure, the risk of restenosis is so high, despite using a two stent technique. Would I be incorrect in saying that?
So I also agree that Dr. Rob's procedure. So considering the patient had several comorbidities and also under warfarin, which requires sometimes triple antiplatelet for some time, that the simple may be the best in this case. But I would also definitely agree that if we have had imagings on circumflex, we may have a better decision. But from the angiographically, at least to my eyes, there must be some disease, but it doesn't seem to be very significant, so that the simple crossover and doing a good job for the left main LAD may be enough for this specific case.
So just very quickly in a few seconds, this was a Journal of Cardiovascular Intervention by some authors who collected data and showed that the 5-year outcomes of a single crossover, was much better, than doing a two-stent technique. The restenosis rates were much lower, like less than 5 to 10% versus higher numbers closer to even 10 to 20% with a two-stent technique. So I think in the interest of time, we need to have Vlad's presentation and do a brief video on reversal wiring. Thank you.
Thank you. So who is the next speaker?
Vlad is the next speaker.
Okay, so Dr. Javik.
Yes, thank you very much, Professor Chen. And here's this was not a 001, okay? And it was I am sharing. Is my presentation okay there? Yeah, I think so. So very simply, this was a 79-year-old woman who presented with several week history of low-level exertional angina, so high-grade angina over the past few months. She had undergone coronary angiography that revealed the following. So she had this essentially dominant circ with a significant lesion in the proximal circumflex and an occluded, almost osteal LAD. And okay, that's better. And so she was referred for revascularization, and my intent was to proceed with doing the CTO, but prior to doing the CTO, I was going to fix the circumflex. And I'll show you, you may wonder, well, why would you do the circumflex? So here's the IVUS of the circumflex. And we can see that it's fairly significant here.
Also, lipid-rich plaque as the osteocircumflex.
Yeah. So I guess maybe I would just leave this to the panel, how you would deal with this situation. The RCA has no significant disease, but is a very small vessel. I'll go back to the angiogram of the
What was the L like? I mean, was the anterior wall moving?
It was, yes, it was. There was definitely not just viability, but ischemia.
Does the patient has a history of myocardial infarction? No.
An NSTEMI, not a STEMI.
So for me, I will protect some flash, and firstly, I will try to open LAD. But I think another option is that because a LAD is total coded, so another option is that we can use a provisional from third to left main, and then after that, very, very carefully to open LAD. So I think two options.
Okay.
I mean, you could fix the circumflex and then just do a hybrid approach and a lemur to the LAD.
Yeah, I guess the question is the LAD ever seen to be a big enough vessel for a hybrid approach?
Use a cardiac CT to tell you that this way.
Fair enough. Good point. Very good point.
Do you have any collaterals from the right?
No, the collaterals, you can see some faint collaterals from the left, not so much from the right. You can see some faint collaterals here.
Yeah, from obtuse marginal.
Yes. Yeah.
To LAD.
Yeah.
CTOA would be useful as well as a viability study, which is MRI viability.
I think the viability was present. In fact, this anterior ischemia was present. So not just viability, there actually was wall motion there. So we brought her in actually to do this CTO. And because there were really no collaterals from the right, we didn't use the bilateral approach. But first, we wanted to deal with the circumflex. So that's what we did. I think I already showed you the IVUS of the circ. So we pre-dilated, we stented, and got a very nice result in the circ. I believe this was a 3.5 by 20 Promus Premier. This was a couple of years ago. But now she suddenly started to have chest pain and lateral ST elevation.
Did you not protect that marginal of the wire?
No, I did not. I did not. I said at the beginning, this was forgotten. You know, the views were such, and we were kind of focused on going to the LAD, but fixing the circumflex first. So it completely did not protect that OM branch. So now we had this issue. So we actually used the IVUS to find the ostium because we could really not see the ostium of the OM. She was having significant symptoms at this point. And we were eventually able to find it using, first of all, we tried the Xi'an Blue with a turnpike microcatheter. Then we switched to Supercross 90. Couldn't quite cross it with the Xi'an Black, but then we were able to cross with the Fielder XT. And with the Supercross, we brought it across and exchanged back to the workhorse Xi'an Blue wire, and then pre-dilated with this 1.5 by 15 millimeter balloon. So our next view, this is after we had done the 1.5, and then we actually did an IVUS and then went further with a 2.75 millimeter balloon to dilate the ostium of that vessel further. So I guess my next question would be, how would the panel deal with this at this point? So we have flow, chest pain's better. It's actually Timmy 3.
Angiographically, obtuse marginal looks like not too big. And Timmy flow is 3. I think it's just keep it open. So because the patient has stem angina, so I think the plaque at the proximal surface should be vulnerable, unstable. So it's easily to get side branch compromised. So I think it's true. Right now, I will do not touch obtuse marginal too much. I will swift to LAD, CTO.
Okay. Well, we weren't perhaps quite as smart as that. So this is actually what the IVUS looks like at this point. So I don't know whether that alters your decision tree in any way or not, or you're still happy to go with a provisional approach.
Even though there's some dissections at the ostium and lumen doesn't seem to be perfect, but I generally leave this kind of lesion alone, or considering finish the treatment with the DCB of that branch so that
right. Well, I mean, DCB is just going to be another balloon, so there's still going to be plaque there and possibly some dissection. So that was my thinking. So I treated this in a little bit more of a complex way. And we decided to treat this with a reverse crush. I personally thought this was not a small OM. This was the only major OM that this patient has. It's actually, as you can see in this view, it's quite a big OM. So we deployed a 2.5 by 23 Zion Sierra, and then did a pod crush with a 4.4 by 8 non-compliant balloon. By pod crush, I mean that I land the distal marker of the balloon just at the carina so that I crush the entire stent. I do that with my DK crush as well. And then we had this. So this is after the crush. We were then able to recross with a Xi'an blue. And I think this was sort of a mid-cell recross, which I like. Like with a first step in the DK crush, you don't want to go too distal. You want to be proximal to mid, from my perspective. And then we utilized, I believe, a 2.75 NC balloon at high pressures, and then a KISS at low pressures, 8 to 10 atmospheres. And this is what we ended up with. Unfortunately, we weren't quite ready to go to the CTO yet. And at this point, perhaps it would have been wise to leave that to another time anyway. But at this point, she had recurrent chest pain, and this time more inferior ST elevations. So you may be right that my enthusiasm to treat I think it's actually a large OM, to be quite honest. And I think some of the collaterals to the LAD were actually coming from that OM. So that's why I was so intent on treating it well. But in the process, I think I had a wire mishap distally in the PL branch, and had to retrieve this, and actually ended up with a good result in the end in this vessel, with resolution of pain, resolution of ST segment elevation. And this is the IVUS from the OM into the circumflex.
How did you retrieve it? Just balloon only?
Yes. Yes. I got good Timmy flow. I did not want to put stent into that distal tortuous vessel. So I think we have a very nice transition there. So that's and this is distal circ to circ. And I think the circ itself looks excellent with the reverse crush in the middle. So we brought her back 2 months later. And this is what the circ system looked like. We then opened the LAD. This is actually real-time wiring of the LAD CTO. And this was our LAD after first pre-dil with a small, I believe, 2 or 2.5 balloon. And then after a lot of other work, we ended up with this.
Amazing.
Well, I think in the interest of time, that's a great presentation, Vlad. We need to wrap it up, but we have if the panelists have questions, please proceed. Otherwise, we wrap it up with the reverse video, wired video that we need to show. Okay, so Bill Nicholson is the Director of Interventional Cardiology for Emory, and he was delighted to make this video for us. Unfortunately, he's on vacation, but we'll show his presentation. Bill has done a great job in expanding the interventional cardiology program at Emory to a supernatural level, I think. But we'll show his video now. So go ahead and play it, please.
Okay, I was going to walk you through how to do reverse wiring. It's typically utilized in these scenarios where you have a retroflexed vessel that you're trying to get into. As you can see, this septal here is going to be very difficult to get into if you come down the coronary, but if you were coming up the coronary, it looks like it'd be very easy to slide into that. So this is a way to get to wire downstream and then be able to wire it on the way back. I'm going to show you a video of how to do this. Reverse wire, we're going to have a wire already down the coronary, obviously. So we're going to use a dual lumen microcatheter. You can use a twin pass torque, or you can use the Suzuki here in the States. And so we're going to have, this is on the RX portion of the wire, and then we're going to put a Xion black all the way through. We're going to push that out. So this will come out the second port. Okay, perfect. And so for this, we're going to put a bend on. The bend I pick is a bend that we're trying to envision what we would want to curve into if we were coming from the distal coronary to the proximal. So we're going to put a nice angled bend, something like that, that's going to hook at that point. And then if you give me a little bit more wire, about 2 centimeters back, right about here, we're going to do an encouraged bend to go the other direction. So don't make it a hard bend because it won't unkink once you wire. It becomes very difficult to get that fold to go away, make it harsh. And so it's just an encouraging bend like that. And so he's going to pull this back so that first bend is just barely at the tip, right? Like a little bit more, right? Like that, good. And he's going to hold them together back there. And I'm going to feed this in, and I'm going to let the co-pilot or whatever you're using bend this backwards and put it up like that. And so at that point, we're going to push it all the way up. I'll show you deliver it to the screen. That way, Noki the whole time is holding the two together, so I don't get the microcatheter out in front of the bend, or it doesn't get behind it. And so we'll run that all the way up, and then we'll reverse wire. So you can see we use that dual lumen catheter to take the wire that we've bent downstream to where we want to be, drop it off, and pull the microcatheter back. Now the wire is basically in that hairpin conformation by itself downstream, and we're just going to bring it backwards. And as it comes backwards, that curve is going to catch the retroflex vessel, but it's not retroflex coming backwards, it's retroflex going forward. So it's perfect for us to catch this direction. And then it's just a gentle maneuver to try to get that final turn to undo and go down the vessel. And so that's how you do reverse wiring. We've done it a bunch. We use a Xion black almost all the time. I think it's the best choice for it. We've been through virtually every other option that you could think of, and that's sort of where we've arrived at. This was one done by my partner, Dr. Sandasar. who had this lesion in the distal right. And you can see it'd be very difficult to wire up and down and around to the PLV, but you can see how he used reverse wiring here very easily to go from the PDA and get out the PLV branch. And it's a gentle process, but the wire will find its way after you engage it, and beautiful result. And this is one more example, just a really neat one. This is a CTO that we couldn't get to through the distal cap initially, but you can see the septal fills retrograde and fills into the distal LAD. As we were working, we ended up in the septal, so we still hadn't crossed the CTO, but we entered the septal, and that septal then communicates with the distal LAD. So we did the same thing. We brought a wire down into the septal as a reverse wiring technique, thinking as we come backwards, we could wire down the LAD and just sort of go around the CTO segment. And so we dropped the wire off down into the septal, back to microcatheter up. And then as we back the wire up, you see how the wire is going to go straight down the LAD for us. Takes a little bit of maneuvering back and forth to just kind of undo the angles. And then we're able to drive that down into the distal LAD.
Very nice.
That's the end of the presentation. So any final comments from all the panelists, any specific issues discussed before we wrap it up? Charlene, you can lead if you want, and John, if you have any questions.
I think we thankfully we covered the questions already, so we're in good shape.
Thank you. Charlene and others?
Yes, thank you, Chavi. I have no more question.
Mamas?
No, a great seminar. Thank you.
Vlad?
I'm great, thanks.
Dr. Koo, Dr. Nam, and
Very nice cases, nice discussion.
Nice
Great discussion.
Yeah, so I really enjoyed the meeting, Andy. I don't have any further questions, so I learned a lot. Thank you.
Dr. Nam?
No more. Great
Well, thank you
discussion.
all. This is a very important topic for bifurcation enthusiasts, and I think we covered most of the ground. I hope it was useful to people who watched us. This webinar has over 10,000 attendees at times to both Twitter and Facebook Live and all over the world. I'm very, very grateful for your participation. And thank you to the SCAI staff, particularly Josh and Bob, who contributed. Thank you very much and good night.
Thank
Thank
you.
you. Bye-bye.
Thank you.
Bye.
Bye-bye.